an outcome measure in early life. So we know that without an outcome measure that's accepted by authorities, we can't do clinical trials, or the drug companies won't do clinical trials in infants and young children. And as with most of medicine, it's easier to prevent than to cure. So for a lot of these new therapies, which hope to prevent the lung damage occurring from CF, if we can start these from birth, it's much easier than waiting until the children are older, they have the lung disease, and then trying to reverse it. So I'm going to go through the technique called Fragment, which we developed. So up until now, there's been no outcome measures in CF for young children, and the reason is the traditional ones are lung function and those kinds of tests that you do when you're older, which are often normal in early childhood. And in fact, CT is one of the earliest signs of lung disease, and it's often the only evidence of clinical disease in infants with cystic fibrosis. And we can see changes on CT right from birth, as young as 3 months of age. The problem is, CT, as you see here, produces a picture, and unfortunately the authorities don't accept pictures as evidence of intervention being effective. So what we need to do is be able to get out a number from these so we can track how the lung disease progresses or gets less over time in normal course of disease or with therapies. And all of the numbers people have tried to come up with have all been in older children and adults with CF who have substantial lung damage, and nobody's looked at the really early mild lung disease that we see right from birth, which is potentially reversible. So what we've done in collaboration with our colleagues and friends in the Netherlands is come up with this method where we can actually put a grid over the CT scan of the lung and actually get a volume of the lung that's affected with disease, which we express as a percentage. So what percentage of your lung has disease in it? And we've done this in a whole bunch of children from the ages of 0 to 5, but for the paper we just published, we looked at the age 1 and age 3, which is really the ideal starting point for intervention. And what we can show is this is sort of the picture that we get, where the green is healthy lung, and the other colours are different kinds of abnormalities we see in the lung. And if we count up the amount of red, yellow, purple, etc., and look at it as a ratio with the amount of green, we can see how much the lung is affected by CF lung disease. And what we've shown is, on the left there, we can see a graph of a bunch of children aged at 1, and then the same child with a CT scan at the age of 3. And we can see that this is the percentage of the lung affected, and it's mild. Nearly all children are less than 5%, even by the age of 3, generally less than 10% of their lung is any lung disease. And we can track these small changes of a few percent over their first few years of life. And to give you an idea of what that means, thankfully Luke already talked about neutral elastase, so the enzyme that represents the inflammation and causes damage to the lung. This box here represents how the children that have no neutral elastase at the age of 3, and they all increase by less than 2%, or nearly all increase by less than 2% of their lung damage. Whereas the children who had the neutral elastase at the age of 3 were up around the 3 to 5%. So not only can we track the small changes in disease, we can actually see the difference in different clinical types of patients. And the great thing about this is we can start looking at early intervention trials in infants. So we've submitted this, or we're about to submit this paper that just got published and a proposal to the European Medicines Agency and hopefully the American authority as well to use Fragment as an official clinical outcome measure for clinical trials, and we can work with drug companies to start looking at these medications they're using in 5, 6-year-olds and really starting them right from birth. These are just some examples of pictures of upcoming therapies and measures that we can look at, with CT being the focus, because that's the end. All right, so, and what really... Ask all your hard questions to Luke.
Don't just run away yet. It's not that easy. I thought you might try dashing away. Do we have questions from the floor?
Sorry, I've got another one. It looked really robust from what you showed before, but how operator dependent is Fragment, like when you're coding the lung in terms of lung disorder?
So we've looked at a couple of observers, so myself, a medical student who was visiting, and other people around in the Netherlands and here that have tried it. So we have a repeatability measure we call the RCC, and basically 0 means everybody's completely different, and 1 means that everyone is exactly the same. So our method scores 0.9 between observers and within ourselves repeating. Other measures looking at our previous measures we used were around the 0.7, and the standard methods everyone uses, which are based on adults, are much lower than that. So it's extremely repeatable, which is one of the reasons why there's been active outcome measures in this age and in a repeatable measure. And further to that, the next stage of my postdoc, which I'm going to be doing partly here and partly in the Netherlands, is looking at automating this, so we can get machines to look through a big database of images and then look at the CT scan and compare, and hopefully get an automated way which will remove the observer.
Like an algorithm that will just spit out a number.
Yeah, that's the goal.
Well, Tim, thank you very much for your talk. Tim, there is more thinking juice out there, and I'm sure that there are a few questions here which people are a bit too shy to ask, but there is no such thing as a stupid question. Ladies and gentlemen, please thank you. Now, before I hand over to Steve, I would like to acknowledge the huge payback that the CF community is receiving from the PhD top-up scholarships we've been able to provide to researchers at the Telethon Kids Institute. These scholarships were not exclusively for the Telethon Kids Institute, but open to all researchers across Western Australia, and we're hopeful that some of that will actually flow forward to adult CF as well in the future. They've been made available thanks to the generosity of the CFWA members, the SBA Foundation, the McCusker Charitable Trust, the Long Distance Runners, and the 65 Roses Ball Committee, which is now Conquer CF. Each of the scholarship applications has undergone a rigorous evaluation by the Australian Cystic Fibrosis Research Trust to ensure that only the best research and researchers are funded, and I think they're doing a pretty good job. The 5 scholarships we made available are now drawing to a close, and the board of CFWA has asked that we secure funding for a further 5 scholarships to be launched later this year. So if you're interested in funding one of these individually or as a small community fundraising group like the Long Distance Runners, please let us know. The 2015-18 scholarships will be $33,750 each, and 100% of the funds raised will go to these researchers. Nothing is taken out for administration by the ACFRT for assessment of the applications, and all the administration costs in Western Australia are met from members' funds. Well, having given that small commercial, I would now like to hand over to Professor Stick to highlight future plans.
And as you can tell, the scholarships are very valuable, but they're not enough to keep people in smart clothes, and but they get the research done, which is all that.
You've only just started wearing long pants.
That's what $12.5 million does for you. Sorry, Tim, but I just had to. What I'd like to do is highlight a few things, and there's going to be one or two announcements that I'd like to come to at the end. The first thing is that there is a global pipeline of new discoveries that can be translated into interventions, and we're part of it. We're an essential part of it. And you can be sure that we're doing everything we can to bring new interventions to patients as quickly as we possibly can. And I think the study that Luke talked about with the antiprotease, that's important because it's a drug that's already been on market. So it hasn't got to jump through a lot of the hurdles that a brand new drug like Kalydeco would have to go through. So we're really much focusing on drugs that are already out there, but that might have a good benefit for children if they're used early on to prevent lung disease. The next thing is precision medicine, and I'll introduce someone in a minute to talk a little bit more about that. But this notion of precision medicine, where not everyone is the same, they don't all respond to drugs in the same way. They might have a much bigger benefit, they might have more side effects. This notion of precision medicine is getting more and more important, and we're incorporating that philosophy into our research. So all of the data that we talked about being in the data sets and the biobanks is being used to try and identify children who might benefit from certain therapies more than others, and identify children who perhaps we might have a more aggressive surveillance program, more investigations, and those that we can afford to relax a bit about. And the other thing that's really new for us, which only really started in 2010 with any gusto, led by Linda Shields, who's a nurse who has an honorary position here but is now working in Townsville, and Tonya Douglas, who some of you may remember was one of the physicians in the clinic, who's now in Queensland. They really did the groundwork. They attracted Cindy, who will talk in a minute, to this area of what are the psychosocial and educational impacts. And the data that we're getting from those studies has now attracted one of the foremost researchers in education and health, Donna Cross, who's a former West Australian of the Year, to work with us since she's joined the Institute, which just goes to show that once you start doing things well, you can attract expertise who want to work with you. And that's what we're doing with our internal collaborators, what we're doing around Australia, and what we're doing around the world. And then finally, I'll say a little bit at the end after Dan Cowdrey and Cindy have spoken about consumer participation. And then we can have some more drinks. In terms of the pipeline, I just want to show you this, because I think this is really quite something. Part of our expertise is growing these lining cells of the airways, and then being able to do experiments to see whether or not we can make the protein that causes the problem in CF work more effectively. And this is the bottom of the dish that the cells are growing on. These are the cells from the patient. This is what's called the airway surface liquid. This is the liquid lining the airways. And in cystic fibrosis, because of the protein abnormality, there's dehydration of the airway surface liquid. The airway surface liquid height is not very good, and the cilia here, the little hairs on the end of the cells, can't beat very easily, and therefore you get mucus build-up and obstruction of the airways. What we did is culture some of these cells with some human stem cells. And what you can see is the airway surface liquid here has more than tripled in height. More than you need to get the cilia beating properly. So this is one of the areas that we're really working at the cutting edge in terms of therapies. And we were fortunate to get some money from the New Children's Hospital program, and this is a program that we hope will get funded by the NHMRC now that we've got the clinical data. So I now want to hand over to Dan Cowdrey, who has come to work with us for 2 years. He's the Rothwell Family Fellow. It's a new fellowship that has been made possible by the generosity of the Rothwell family. And his interest is in precision medicine and using the data that we've generated to help us better understand the risks involved in future disease by certain patients. So, Dan, come and tell us what you're going to be doing.
So thank you very much for inviting me, Steve, tonight, but of course thank you very much for inviting me here for 2 years. It's really a great step. So we'll be starting in 2 weeks, but well, very nice to be able to introduce myself. A lot of people, obviously, I don't know, but even the people working in the institute, I've not seen, so I thought I'd take the opportunity to introduce myself a little bit more. So I'm a medical doctor in Rotterdam. I did my studies there. I'm also a clinical epidemiologist, so that's useful for the studies that I want to perform here. I did my PhD in asthma and wheezing in childhood, so it's a different subject, but I did a lot of prognostic modeling in asthma, and that's exactly the type of thing that I would like to do here as well. I did my residency in pediatrics, so I'm almost a pediatrician, and I hope to become a pediatric pulmonologist due to my fellowship here in Australia. And I've been working part-time during my residency on CF, so I have been doing a lot of CF work the last 5 years actually. I have a family, a wife and 2 children, so it's quite a big step to go from the icy Netherlands to Australia. This is really in Perth, that's Koala English, just to make sure that you trust me there. So really excited to come over. And what I would like to do is do advanced prognostic analyses in children with CF.